Welcome to this Specialty Pharmacy Times peer exchange discussion. Today we're going to discuss hemophilia. Hemophilia is a rare disorder in which the blood doesn't clot normally due to insufficient blood clotting proteins or clotting factors. The most common types are hemophilia A with a factor VIII deficiency, hemophilia B with a factor IX deficiency. A person with hemophilia may bleed for a longer time after an injury than a person without hemophilia. That person would clot normally. The concern is with deep bleeding inside the body, such as in the joints, the knees, the elbows, the ankles, that can cause tissue and organ damage, and also bleeding in the head, which can cause serious neurologic injury. Throughout this discussion, my colleagues and I will take a look at the recent advances in therapeutic options for the management of hemophilia. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University College of Physicians and Surgeons, and an associate director of surgical intensive care at New York Presbyterian Hospital. Participating today on our distinguished panel are Tim Boonstra, pharmacist and pharmacist site manager of Fairview Pharmacy Center for Bleeding and Clotting Disorders in Minneapolis, Minnesota. Lacey Chapman, pharmacy manager of Factor I Source Fast Pharmacy and PRN pharmacist at Johns Hopkins Bayview Medical Center in Baltimore, Maryland. And Dr. Robert Sidonio Jr., assistant professor of pediatrics and associate director of hemostasis and thrombosis at Emory University School of Medicine in Atlanta, Georgia, and Children's Healthcare of Atlanta. I want to thank you all so much for being with us. Why don't we get right down to it? This is a fascinating discussion. Why don't we start with some basic definitions? I want to know, our audience would like to know, your definition and the differences between hemophilia A, hemophilia B, von Willebrand's. Where do we go with this?
So we can start with the most common bleeding disorder, that's von Willebrand disease, and that's a deficiency or defective von Willebrand factor, and that's as common as 1 in 1,000. In some studies, it might be as common as 1 in 100 with very, very mild reduction. That affects both men and women, and it's typically autosomal dominant with some rare ones being autosomal recessive. And then there's, more commonly known hemophilia A and B, and we use the terms factor VIII deficiency for hemophilia A. And there are 3 main severities for that. It's about 1 in 5,000 males have that. These are X-linked disorders. And then hemophilia B is much less common, about 1 in 25,000 males. And that's a deficiency or defective factor IX.
Now, hemophilia B is called Christmas disease.
Yes.
I've got to ask,
Yes.
because I forgot.
Yes.
Why?
So it's named after the first patient. It wasn't the first patient that was diagnosed, but the first one that was described in the literature and named after that family. And it is actually, when you look back, that the royal disease label that's often put with hemophilia, when you look back and they've actually traced this, Queen Victoria was a hemophilia B carrier, and we all know that history of how that spread throughout Europe and actually changed history.
It did. In fact, we always talk about this, at least in medical school, because people like to. The czars,
Yes.
who were genetically linked to the royal families elsewhere, their male offspring often had this. But I didn't know that it wasn't 8, it was 9.
It was IX deficiency. They went back and traced this, and it was interesting when you look at those same czars and the Tsareviches, their doctor was actually Dr. Rasputin, and he probably helped them the most by not doing anything, because some of the interventions at that time were actually probably harmful for those people.
Mm-hmm. And the other thing I think you mentioned, and if not, let's bring it up, there's a spontaneous mutation rate. Right?
Sure. Yeah, and so in von Willebrand disease, we don't know exactly what that rate is. It's probably less common than in hemophilia, but in hemophilia A and B, the spontaneous rate is about 30%. And so oftentimes there's no family history, which often makes it very difficult when you're dealing with a patient that's bleeding and you don't know why, because there's nothing to trace back to that.
Well, the reason I ask is, let's go back in history. After the Russian Revolution and the czars were gone,
Yes.
Hemophilia didn't disappear in Russia.
It did not. So, and it's been around since, people have recorded this, and we've talked about this, and, it's recorded in the Talmud. It mentions hemophilia. That doesn't mention it by name, but it's a bleeding condition, and it talks about not circumcising the second child that dies. You have to have at least 1 or 2 children die, and it talks about how the mother's sister's sons don't have to be circumcised as well. And so they obviously understood how it was transmitted. They understood that it was something that was there. They just didn't have a name for it.
Wow, it's always fascinating to go back to the ancient literature. Mm-hmm. They knew about this. They didn't know about X and Y chromosomes, but they knew transmission before Mendel.
Yes, I know. It's pretty amazing. And, and even in von Willebrand disease was one of the ones that are actually named after the founder. Eric Adolph von Willebrand's, and he discovered this in a tiny little island, the Uland Islands. And the first case was a little girl named Hjortis who had devastating bleeding events. And they initially called it pseudohemophilia because they were seeing this in girls and they didn't understand why. And unfortunately, that girl died after her 4th period. And so it wasn't till a couple decades later before they figured it out.
I gotcha. Well, let's talk about the genetic predispositions leading to hemophilia. We've got the prevalence of hemophilia A, B, von Willebrand's. What does that look like?
Well, there are about 20,000 hemophilia patients currently in the United States. And for von Willebrand's disease, it probably affects about 0.5% of the population.
That's not small.
No,
Yeah.
But there are kind of varying degrees of severity. And there's type 1, type 2, and type 3. And depending on what type you have, you may or may not need treatment.
What about A and B? What was the prevalence of that?
Generally, there's 80% of the hemophilia patients will have type A, and then 20% will have hemophilia B.
And let's talk about now the mortality rates, treated and untreated. If you leave this alone, if you were Rasputin and you don't do anything, what's the mortality rate for each of these, A, B, and von Willebrand's?
Well, I'd say the mortality, I don't really like to go mortality rate necessarily. I guess if it's untreated,
Yeah.
certainly there are certainly some serious morbidity involved with that. But it certainly has changed over the years.
Yeah, tell me about that.
From kind of being not very effective treatments kind of early on in the 60s and 70s, not very good treatment. And then in the 80s, of course, there were the dark days of kind of hemophilia with kind of the bad blood supply, which we had kind of a HIV epidemic, and then also Hep C was during that time. And
I was practicing during that era, and I recall virtually the entire hemophilia population of the United States being wiped out.
Yes.
Correct.
It was the most tragic thing.
Yeah, it certainly was a very kind of dark days. But now they're certainly in the 80s with being able to get rid of those viruses out of the blood supply. Viral transmission is virtually unknown today.